Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. Today's presentation is from Dr. Jonathan Fitzsimon. Dr. Fitzsimon graduated from the Sheffield University Medical School in the UK in 2007. From 2009 to 2010, he worked as a volunteer physician in Urujo, Bolivia, before returning to the UK to complete the General Practice Specialty Training Program. He moved to Ontario in 2014 and started a family practice in Renfrew County. In 2020, Dr. Fitzsimon was appointed as medical lead of the Renfrew County Virtual Triage and Assessment Center, medical lead of the Petawawa Integrated Virtual Care Program, and assistant professor at the University of Ottawa. He was previously chief of medicine at Arnprior Regional Health. Dr. Fitzsimon was the recipient of the OMA's 2021 Glen Sawyer Service Award. Due to technical difficulties, we will use a voiceover for the first few slides before turning it over to Dr. Fitzsimon. Why do we need virtual care? As per Dr. Yu Sylvie, sometimes a patient cannot come to us. We need to go to the patient. The Canadian Institute for Health Information defines virtual care as any interaction between patients and members of their circle of care, occurring remotely, using any forms of communication or information technologies, so phone, video, secure messaging, with the aim of facilitating or maximizing the quality and effectiveness of patient care. What is hybrid care? In-person care complemented by virtual care. The bottom line is, you must consider patient needs along with the presenting condition. Whether delivering care virtually or in person, the fundamental principle is that the quality of care is not compromised and the standard of care is met. You must balance clinical need with patient preference, utilize the advantages and strengths of virtual care, have in-person options available when needed. Person-centered care requires putting the individual at the center where care is collaborative, coordinated, and accessible. Patient and family preferences, values, cultural traditions, and socioeconomic conditions are respected. The goal is to empower patients to become an active participant in their care. The objective being that the right care is provided at the right time and in the right place. Many patients like virtual care options. The Canadian Digital Health Survey of 2021 shows a 90% overall satisfaction with the care received. 91% indicated that the virtual visit saved them time and money, and 81% indicated that the virtual visit avoided an in-person visit to a doctor or ER. We are now turning it over to Dr. Fitzsimon, who is speaking to the nature of virtual care and impact on ER visits, especially for unattached patients.
There we go. Now I'm going to go to where I am currently. So some of you may have seen this slide before. If you've heard me speak before, Renfrew County, it's the largest county in Ontario. There's 7,500 square kilometres, home to about 108,000 people. And there's a mix of semi-urban, rural and remote communities. The county includes 5 towns that have their own community hospital and emergency department. But there are many small rural and remote communities around Renfrew County. There's the First Nation community of Pikagonagon, and there's also the large military garrison at Petawawa. So there's certainly diversity amongst this mostly rural and semi-urban county. Compared to provincial averages, the population here is older, poorer, and has higher rates of chronic disease. It's important to note that there are no walk-in clinics or urgent care centres anywhere in Renfrew County, and unattachment rates are almost double the provincial average. So what this results in is basically a massive over-reliance on the emergency departments. So in 2020, part of the pandemic response, we set up the virtual triage and assessment centre, now universally known as VTAC. I know, not the best name, but VTAC it is, and VTAC it will stay. And like I say, this was part of the response to the pandemic. It was initially formed as a COVID assessment centre. It became a clinical assessment centre, and then with directions from the Ministry of Health, we adapted to meet the call for respiratory and influenza-like illness assessment centres. But we've had a focus from day one of being able to provide an alternative to the emergency department for patients who have an urgent health concern, don't have a family doctor, can't access their regular primary care provider in a timely manner. We also had a priority that the process should be simple and straightforward, and that all residents should be able to access the service. And so the entry point is a single toll-free phone number. We have a team of medical receptionists. Most of them work part-time for VTAC, in addition to their regular jobs in doctors' offices across the county. So they register the patients and set up a chart within our electronic medical record, and they schedule an appointment, usually same day, with a family physician. Clinician assessment takes place. We also have this sort of combination of family physicians working alongside paramedics. So we have paramedics based at the assessment centres, and they, in the early days, were focused on COVID testing, but then as time went on, that progressed to doing more aspects of assessment and care for a variety of conditions. So whoever the clinician is doing the assessment, whether it's physician or paramedic, whether it's virtually or in person, whether it's in our one of our assessment centres or whether it's at home, the result forms one of sort of three sort of pathways. Either we treat and deal with the issue there and then, we escalate it, which could involve ordering tests or investigations or referring to a specialist. And of course, there is always still that final option of recommending to patients that they have to go to an emergency department or even calling 911 there and then. And so that's what I mean when I talk about a hybrid of hybrids. So we've always had this tremendous resource in Renfrew County of our community paramedicine program. As I mentioned, we've got a severe shortage of family physicians. But by bringing together family doctors and paramedics, we've been able to tap into this tremendous synergy that comes from this partnership. So in a rural community, the process of transferring an elderly patient to an emergency department, that can tie up a paramedic and an ambulance for 4 hours or more. And in the end, the end point is often a patient who spends many hours waiting in an emergency department. They get quickly discharged once a clinical assessment is complete. And then sometimes the patient has to be transferred home again. So VTAC provides the opportunity for paramedics to quickly link with the family physician and provide that additional reassurance to the doctor of having somebody eyes on with the patient, taking vital signs, doing point of care testing, and bringing their own clinical knowledge and experience to this hybrid consultation. So we've invested in the paramedics. We've done training. We've bought specific equipment. We have digital otoscopes, digital stethoscopes. So we've enhanced both the skills of our paramedics and the equipment that we have and the functionality of the assessment centres that we use. And of course, the family physicians are available virtually to support this process, to do this combined consultation or appointment, where the paramedic is with the patient in person and the physician is available by video or phone. So VTAC provides this incredible service for acute episodic care, especially for patients without a family doctor. VTAC is that alternative to the emergency department or simply suffering at home in silence. But we wanted to go further. We wanted to move beyond acute episodic care and take the strengths of this hybrid approach and utilize them to offer to some patients attachment to comprehensive team-based primary care with family physician leadership. So we approached a local family health centre that has a family health team with a range of allied health professionals, but they've been unable to recruit more family doctors to resettle in the area and set up a practice on site. So we recruited family physicians who work predominantly remotely, and they're fully embedded staff physicians in the family health centre. They each have their own roster of patients. They're responsible for their patients' care. But they're fully supported by the allied health team and the group of physicians and nurse practitioners that are on site. And so what we find is that we have physicians, again, working predominantly remotely, but now they can be enhanced by allied health, again, using these equipment and techniques, things that other specialists have used through telemedicine for many years, actually, but perhaps we've been slower on the uptake in primary care. So when you start using different cameras, digital stethoscopes and the like, you can really enhance what the physician is able to do, even if it's a relatively low qualified assistant with the patient in the exam room. So it could be a medical office assistant, which is doing many of these things. So since March 2020, VTAC's completed over 80,000 family physician virtual assessments, had over 70,000 COVID tests and on-site paramedic assessments, which, as I explained, has now progressed to a much wider range of conditions and symptoms that they can assess. And we've had over 5,500 paramedic home visits that support vulnerable and housebound patients. So going back to that original Dr. Sylvie quote of sometimes literally having to go to the patients. But what I would say is that what we've done is we've taken that initial simplistic sort of interpretation of that statement and shown how we can go to the patients in a whole variety of different things, different methods. And in a recent 30-day snapshot, VTAC received over 5,000 calls, and we provided close to 3,000 physician virtual assessments, 170 in-person assessments. And and I would point out, just a reminder, that on any given day, 70 to 80% of the patients that get an appointment with VTAC don't have a primary care provider, they don't have a family doctor. And in some parts of the county, that number is 90% plus of people using VTAC. So 34%, so over a third of patients report that they would have gone to an ED if VTAC had not been available. And yet less than 3% of our encounters result in the physician advising the patient to go to ED or calling 911 there and then. And so that translates into around 1,000 emergency department attendances diverted or avoided every month. So with the integrated virtual care program, we now have over 2,400 patients enrolled to an IVC family physician, previously unattached patients now having attached on a roster with a named family doctor. And they've had over 6,000 appointments with their new doctor, over 3,000 appointments with the allied health professionals in their local family health team. And hundreds of these patients have now had access to preventative care measures such as cancer screening and smoking cessation. And what we found for many of them, it's the first time ever that they've had access to that care. And not surprisingly, the majority of patients love it. They've gone from having a trip to the emergency department as their only option to access healthcare to now having a named family doctor, access to a team of allied health professionals, being part of their local clinic, and they can have in-person care or virtual care depending on their individual clinical needs and preferences. So we've published papers on the output of VTAC during the pandemic, and we have a series of papers under peer review, others currently being prepared, and together they clearly show that hybrid models of care can meet all aspects of the quintuple aim framework and improve equity of care for people in underserved communities. We used Ontario's population level health data, so that's ICES, and completed an extensive analysis of the impact of VTAC. And I am delighted to share with you, literally hot off the press, 2 and a bit hours ago, I got an email from the British Medical Journal saying that this paper has been accepted for publication in BMJ Open. So really adding weight to what we knew and what now we've been able to demonstrate and publish, that we can, with the VTAC model, we can show an overwhelming reduction in unnecessary emergency department visits, reduced hospitalizations, and also millions of dollars of total healthcare cost savings each year. With IVC, we've shown that patient experiences is as good or even better than the levels shown in published research on patient experience with other virtual care, and is comparable or even better than patient experience with traditional forms of primary care as well. So I hope I've shown you how VTAC has provided additional ways for patients to connect with a family physician, how hybrid care, whether that's talking about virtual and in-person, or physicians with paramedics, or in-person and at home, in clinic and at home. Hybrid care has opened new opportunities for acute episodic care without resorting to an emergency department. And how VTAC's work alongside the integrated virtual care program has provided, I would say is a really innovative approach to increase these opportunities for unattached patients to actually enroll with a doctor and receive comprehensive team-based care with family physician leadership. These programs help residents to be better able to navigate the healthcare system. They can now utilize resources that they've never previously had access to, or perhaps didn't even know about because they didn't have a family doctor. And I hope I've shown that we can really improve healthcare equity by increasing access to care in this way. Okay, I'll finish there. You can feel free to reach out to me offline if you want any more details. There's my email. You can see a little bit more about VTAC on our website.
Jonathan, thank you so much. That was a fabulous presentation. I think you've touched on a whole plethora of critical care points in our system. In terms of access to care, team-based care, it really, it really is a model for sure. I was wondering if I could just take the first question. I see David's got his hand up. just wondering around partners in terms of expanding this, in terms of sustainability, longevity, and like the Society for Rural Physicians Canada, for example, is an advocacy group for this kind of thing. I was wondering if you could maybe speak to partnership.
Yeah, I think word has spread for sure. More and more people are aware of VTAC and IVC. Just a few weeks ago, there was a big announcement, which we were all very excited about in Renfrew County, that the government has confirmed long-term funding for both VTAC and IVC. You know, I've presented these programs at a number of conferences, both provincially and nationally. We've had interest from you know, outside of Ontario. So I presented to Health Canada's equity working group on access to primary care. There's interest at the CCFP level as well as the OCFP. We're a partner with Health Excellence Canada. We're actually one of the care innovation partners. And they've selected 3 programs from across Canada to be examples of demonstrating what good innovation looks like. And we're working with them to show how we went through the process, which will help them identify things in the future. IVC is hopefully in the very near future going to expand to a second site. We continue to grow with that funding. We can take on more patients. And like I say, VTAC has the security of the funding announcement now. So I think the future looks good. I think as we continue to evaluate and show the outcomes, you know, literally proving what we can do, then I think other regions, other areas will want to have access to this sort of model as well.
Thank you. David.
Yes, Jonathan, what a great presentation. Just the background, the timbre, the tone. Thank you so much. Can you hear me okay?
I can, yeah. Thank
you.
Yep, just
I really enjoyed it. And before I forget, the college, along with the Society of Rural Physicians, is co-hosting a Rural Transport Summit next Thursday at Wabano. Some of the leaders from the college have had to withdraw, and we don't want to give the impression that this is not critical. So if you or anyone in the audience is interested in joining me at Wabano, May 4th, for an all-day event to mark some of the challenges in rural transportation, but any transportation to serve our patients, please let me know. I remember losing a patient in Moose Factory and because of transportation issues. So it's really, really critical. I want to say a few things. I want to say that this indeed embodies not only the patient medical home, but the patient medical neighborhood. There are some patient medical neighborhood evaluation tools on the college website. And this really embodies it, and embodies the difference between multidisciplinary and interdisciplinary care. I'll put a little illustration from my daughter. I know everyone understands this, but we talk about multidisciplinary care, but it's really about moving towards interdisciplinary care and really working together between the disciplines. And that's, I guess, my question is, you know, I spent a lot of time looking overseas. I thought in order to influence models, but just as often we're bringing lessons back home. We have a really hard time with integration in Canada, as the pandemic has illustrated, integration between disciplines, but also integration between sectors. And so my question is, because we're used to having agency at the practice level, and there's all kinds of historical reasons for that, I think, by global standards, it's an unusual amount of agency at the practice level. How have you, your colleagues, and the district engaged with practices, engaged with disciplines, found the funding, and indeed established the governance for this excellent program? And what can we learn about interdisciplinary governance, which is what we're all trying to aim for? Thank you.
Thanks, David. Some really pertinent points there. Let me unpack the engagement and the governance piece a little bit. Like right at the start of the pandemic, it was a unique moment in time when everybody wanted to step up, everybody wanted to help, everybody wanted to be engaged. So when we said, look, this is a huge county, largest county in Ontario. How on earth are we going to do COVID assessment, and how are we going to look after all these unattached patients? What happens if we've got all these people still turning up at the ED? This could be really challenging. So when we put out a call and said, look, everybody needs to get together, we need to figure this out, it literally did mean everybody got together. And one of it's a double-edged sword in a rural community or a rural county, that it's a smaller pool of leaders, in that the same volunteers keep getting their doors knocked on time and time again. But the advantage is when you get there, you know everyone, you've got existing relationships. So it's like I say, it can be a double-edged sword. But what we were able to do was pull in leaders from literally every health sector. So from hospital CEOs, executive directors of the family health teams, the medical officer of health, the chief paramedic, and then pick a health sector or a health service within the community: palliative care, mental health, community pharmacy, home care, long-term care. The leader of that organization came to the table with us. And so we were able to pull that group together. And at the start, that we were meeting twice a week. Now we still meet once a month. And so, you know, that cooperation and that coordination across sectors, I totally agree with the point you're making. It's completely imperative. Like, these innovations don't just happen by one person having an idea and just getting on with it. You have to have that engagement and that buy-in from other, you know, across the sectors and from other leaders. As we now have this more secure funding, and we're looking at the long-term future of VTAC, how we can sort of evolve it. You know, the intricacies of the governance and the organizational structure, you know, is still being discussed and still being debated as we go forward. And I think that's a good thing, because it shows it's a live process. You know, we're willing and able to change with that process. But personal relationships, knowing your colleagues, being able to sit around a table or go on a Zoom call and have meaningful conversations, disagree at times and still be friends at the end of it, you know, that's super important. And these things don't happen without those relationships. I hope that answered the question, David, or
Absolutely. It answered the question. It also raises more questions, you know, how to replicate that model, including in urban settings, right? I mean, what's the governance needed? We've tried so many different things, and you know, our members are not happy when necessarily when they're told to do something a certain way. So, you know, I'm not saying we all have to do this, be standardized and coordinated in the same way, but by global standards, we have an enormous amount of control over our individual practices and who we take as patients, who we don't take as patients, if we do home visits, if we don't do home visits. Like, how do we standardize our sector? We have a good public health sector, we have a good primary care sector, I think, but the two don't often come together for the betterment of population health. I think Claire Liddy has said, you know, we don't have a primary healthcare system. We have a primary care system and a public health system. We don't necessarily merge the two. So, like, what are the governance changes, I guess, at the provincial level required? I don't have the answer.
One of the things I advocate for is that, because I do sit at some regional and provincial tables as well, is that, you know, I always feel like, you know, often alongside Richard Johnson, you know, we're waving the flag for rural communities, but really I try not to make it, you know, all about me. And I say, look, every community is different. You know, there is no one size fits all solution to the primary care crisis. And I think the sooner we get our heads around that, the better. So don't lose sight of the local. You can have themes. You know, when I talk about hybrid care and I say, okay, you've got some virtual and some in-person options there. We use physicians with paramedics, but maybe in your community, in your region, you've got a network of walk-in centers. That could be your in-person option. Maybe you've got an army of nurse practitioners hiding away somewhere. They could be your sort of in-person support options. It doesn't mean that, you know, to benefit from something like VTAC or the integrated virtual care program, you have to do it exactly like we do it. Take the themes, take the threads, take the concept, and make it fit your local circumstances. And I argue that case around family health teams as well. My ideal family health team would work for Renfrew County in a rural community with an older, sicker population. Might not work for downtown Toronto, and that's okay. You know, so design it to fit the local need.
Thanks, Jonathan. Richard, I see you've got your hand up.
Yeah, and I was just going to add on to Jonathan's points there. Some other like local nuances to our region that, you know, have also allowed this to work is we do have a very strong primary care network. And so that network includes representatives from every single clinic in Renfrew County and South Algonquin, both from a clinician, either physician or NP, and the executive director of those clinics. And so we can get broad kind of discussions happening at that network level. And then you can have representatives from the network that then sit on these regional tables that then, you know, can bring the view of that whole group together. So again, for engagement, so we can easily get communication out to the entire primary care community, but then you can get a representative from the sector to go and sit on these areas. So if you look at something like It's Easier Paramedics, you know, that's a regional program that encompasses the entire county. Mental health, you know, there'd be many organizations that would fall, you know, within that. And so we have a mental health network that exists that, again, they can talk about issues. And then, you know, some of those are at the point where they would be nominating somebody to a committee, but some of them wouldn't be quite at that point yet. But you could still get a representative from that sector to sit on a regional table and hope in the future that it could, you know, go down and they could more represent that sector. But even if you can't quite get there right now, at least having a representative that can talk about issues from that sector, not aiming for perfection. When you start a program like this, you are at least making it far more collaborative, and the innovation that Jonathan's talking about to make sure that we're not missing entire ideas, you know, from that sector that needs to be represented. So I think it's kind of a mix of both. And so I just point out the network level as being, you know, another area where we found success in Renfrew County. And so we are trying to build those networks up stronger and governance within them for this very reason you bring up.
Hi, thanks for that wonderful talk. And it makes a lot of thinking. One of my questions is that, Jonathan, I really believe in what you're saying, that you kind of set your goals big at a big level, and then the smaller you go down to the community, the more you make it community focused and have the tenure of that. But when you sit at the provincial tables, how do you see supporting government to be able to put in the kind of evaluation they need to follow their dollars without restricting the program so much that at the local level it looks like the wrong community? Do you understand the question I'm asking?
No, I do, and it's so timely. We're literally in those conversations right now with BTAC. You know, the new funding has brought with it a whole load of requests of new reporting, and that's complex. You know, how do we say this is how I think we're demonstrating success of this program, and square that circle with government saying, well, this is what we want you to show. That is not an easy process. It's not an easy task, and I wouldn't say we've you know, I don't have the magic sauce for that, and the answer, I guess, is to stand your ground and fight your case on that, you know, we need to be able to demonstrate that this works for us locally, but also be flexible enough to say, you're funding this, and if you've got your eye on how could this work elsewhere, we may need to demonstrate other outcomes as well that are less relevant for us, but can then give it the weight to say this could sort of be put in place and scaled and spread elsewhere. Yeah, that's an ongoing question that I grapple with, if I'm honest with you, Alison, and I don't have the answer to that.
No, but it's good to talk about it, because I think that's what we're all thinking. If we want to move funding, if in all of our wildest dreams, someone could realize that primary care is worth more than 60 million over 2 years for an entire province, which in my mind is almost an insult, we are going to have to grapple with how to have large goals, but allow each program to be community focused, kind of like what David was saying, you know, that in Moose Factory, transportation is a big issue. Well, that's going to look totally different in Ottawa. But if you have the same metric, it doesn't make sense. So anyway, thanks. And I appreciate all of your efforts and your voice at all of those tables.
Hi everybody. I'm sorry I wasn't able to catch most of the talk. I'm sure Jonathan did a brilliant job. Jonathan, you do realize that your name tag says duty commander?
I know you missed the start there, Lisa. I had some tech issues. Fortunately, one of my paramedic colleagues in true hybrid fashion leapt to my rescue, so I'm using his computer.
Excellent. Well, two things. First of all, Alison, absolutely on point comment. I think we're what Jonathan's suggesting, tailoring to the needs of the different communities and all that, and it is absolutely what we need. And we are being hindered in that at every step of the way by I'm not sure what the correct word is, but an absolute excess of micromanagement coming from the provincial level. And I don't need to give examples. I mean, we're all many family doctors on the call here, so there's just a huge amount of micromanagement, and I'm wondering if not to mention the complete sort of lack of power, I think, that and agency that the patients are feeling, particularly given the shortages right now. So they kind of take whatever they can get because otherwise they have no family doctor or no access. So I'm wondering if a shift of this whole accountability, and this is a complete paradigm shift, so I'm not this is a big tall order, and it would take a lot of time, but I think if there could be a shift towards more control and agency on the part of patients. In other words, if patients had, for example, a budget or tickets or coupons or whatever you want to call it, and I was just very reminded of that yesterday because I'm actually moving my practice at the beginning of June. I'm within Ottawa, but still moving from a family health team to a non-family health team. So some of my patients who are dependent on a few of the family health team related services are want to follow me, but they need the shared mental health psychiatrist or they're in the process of doing something with a dietitian. So and this highlights again two things. I think one is the huge amount of inequity in our system across the province, but two, also the sort of the level how micromanagement can have these perverse effects. And really, why should one patient, my patient, same doctor, in one setting have access to a dietitian or a psychiatrist or whatever, but let's say dietitian in this case, and same patient, same doctor, dyad moves to another setting, and all of a sudden there's no more access to a dietitian. So I imagine a situation where every patient would have, let's say you're allowed, 3 dietitian consultations every 2 years or something like that, just a bit like the private health insurance plans. And then people either use them or don't use them, and they could go to any registered dietitian in the province. Like, who cares? They don't have to be in a family health team. So I think maybe if we start thinking about giving patients the decision-making power, and ironically, with respect to family doctors, patients already have it, but they don't know about it, right? They don't know that if they're in a capitation model, their doctor is actually getting mostly paid for them being registered with this doctor. But patients aren't aware of that, right? So I think we need to think about moving the decision-making power to a certain extent. And that would then build in accountability, because if somebody's doing a lousy job, people are going to go elsewhere, right? It becomes there's a certain innate or inherent feedback in that type of system, because people will go where they get quality care, assuming they have a choice and they have the power to make that choice. So anyways, that's just sort of a comment. I think that is very relevant to both what Jonathan's been saying and advocating, but also to the challenges that we face that were highlighted by Alison. So anyhow, I'm mindful of the time. Maybe I don't know if there's anybody else who wants to comment, but as a closing remark, I just wanted to and maybe Jonathan, you've already talked about this, but I just wanted to mention that this project, and I think you must have mentioned the BMJ open paper, right? This in a way arose in part due to family medicine grand rounds. And Jonathan, I'm completely blanking out. The pandemic was a blur, but I think it was November 2020, right? Jonathan presented the work. Yes, it was, because it was just after sort of the initial 6 months of VTAC, and Jonathan presented at grand rounds what they had been doing and saying, yeah, and we need to evaluate this and all that. So I got in touch with Jonathan. I said, hey, do you know you can evaluate this using population health data? And happy to help. And that was the beginning of a great collaboration. And I'm so happy to see that the outputs and the results that are coming out of this, and now this publication. So it's really great work, and really to Jonathan's credit, who's been driving this forward very in a very focused manner. So.
Yeah, thank you for that closing comment, Lise. And Jonathan, thanks again for a wonderful presentation.